Another topic for us is femur and knee, means different injuries in the rest of the femur and knee. Now, till now, we talked about proximal part of the femur fracture, but shaft of the femur fracture is left. So we will do that first, and then I'll enter into the knee joint injury or injuries around the knee. Now, femoral shaft fracture. So we all know shaft is a middle part of the femur. The femur is a long bone. It has got proximal end, distal end, and the shaft. Okay, end are also known as epiphysis. Shaft is also known as diaphysis. So in some of the book, it is written as femoral diaphysis fracture. So don't get confused. Look at the picture here. Look at the X-ray. There's a clear-cut fracture. Okay, clear-cut fracture. Okay, it looks like a bit of transverse type of fracture here, right in the middle of the shaft. So regarding the mechanism of this fracture, we need a high energy trauma to break the femur, because femur is very strong bone in our body, and these high energy traumas can be motor vehicle collision, fall from a height, and gunshot wound. Okay, gunshot wound. All these are important ones. In children, it can result from low energy trauma because their bone not that very strong, and that can result in spiral type of fracture. Twisting force is necessary. Pathological fracture can occur commonly in the elderly population because their bone is already osteoporotic. The bone is already weaker. So small or trivial fall or injury can cause the fracture. But having said that, shaft of the femur is still not a common bone to get fractured in this type of situation. The neck of the femur is very common to fracture rather than the shaft. Stress fracture occur mainly in military recruit or runner. Okay, cases have been reported. Now, some important points quickly. It is important to rule out ipsilateral femoral neck fracture as they occur in 2 to 6% of the femoral diaphysis fracture and are reportedly missed in 19 to 31% of the cases. So what does that mean? Look at this X-ray. Can you see the femoral neck in this X-ray? No. Okay, I cannot see properly. Okay, there's not a proper view there. So I need to take this view as well, because in some of the cases, the femoral neck fracture occur together with femoral diaphysis fracture. These are the mechanism of femoral shaft fracture, very serious type of injury. You can see collision. Okay, this bike is collided with the car there. There is a high chance of fracture like this. Now, this slide is telling us what is the mechanism of displacement in femoral shaft fracture, okay, and where the fracture occurs commonly. Now see here is the femur bone, okay. So this is the upper part of the femur, this is the middle part of the femur, and here is the lower part of the femur. So it occur at any site, and it is equally common in the upper, middle, and lower thirds of the femur shaft, okay. And according to the attachment of different muscles, okay, the displacement of the fracture may be different. The displacement of the fracture may be slightly different. See this. Okay, these are the attachment of the muscles here. Now, in children, regarding the displacement, there is not much displacement because the muscle mass is not strong enough in children, whereas in adult, there is a marked displacement because of the strong muscle mass there. So regarding the displacement, the proximal fragment is flexed, abducted, and externally rotated, whereas the distal fragment is adducted and sagging because of the effect of gravity, and adducted because of the adductor. Okay, so this is important for us. Remember, regarding the displacement also, we always look mainly for the distal fragment. We also look at the proximal fragment, there's no doubt. The distal fragment is the one which we look in the beginning. So there's adduction and sagging of the distal fragment as a result of displacement. What are the clinical features now? Just like any other fracture, okay, there is pain, there is swelling, there is deformity, like a shortened leg if fracture is displaced. Okay, and it depends if it is a compound or open type of fracture. I can see the fracture bone there. A lot of bleeding can occur. So all these are important clinical feature. Now it is important to rule out ipsilateral femoral neck fracture, which we already discussed this point. Many of the time, they may occur together. Now let's clinically evaluate this type of case. Now, why this is important? Remember the topic of trauma, okay, survey. A full trauma survey is indicated because this person is having serious injury. Then only the femoral shaft can be broken. Sometimes motor vehicle collision, sometimes road traffic accident, sometimes fall from big height, something like that. So A, B, C, D, and E are done. I'm sure you still remember the meaning of these alphabets. A means what? A means
Airway.
B.
Airway.
B is
Breathing.
breathing. C for
Circulation.
circulation. D is
Disability.
Disability.
disability. Disability. And E means
Exposure.
exposure. Excellent. So A, B, C, D, and E. Very good. So all of these we do one after other. First thing is always airway. If we miss airway, if airway is obstructed or compromised, patient can die quickly. So always airway management first. And along with the airway, cervical spine precaution is also done together. Cervical spine precaution or C-spine precaution, we say, if we suspect there is a damage to the cervical spine, we fix it, okay, or we immobilize it with collar, hard collar, okay, that is together with A. B, breathing, C, circulation, D, disability, and E is exposure. The patient has non-ambulatory with pain, means patient is non-ambulatory with a lot of pain. Patient cannot move at all because femur is fractured and there is a lot of pain. There is a gross deformity, especially in displacement. There's a massive swelling there, okay, and there is shortening of the affected extremity, again because of displacement. So these are classical features. Nobody can miss a femur fracture because of these clinical features. A careful neurovascular examination is essential. We always do that, always. In any case of fracture, the distal part of the limbs has to be examined. Whether pulse is present or not, what is the capillary refill, time there, is it warm or not, is there sensation present or not, what is the motor power, what is the reflexes, we always do that. And a careful assessment of hemodynamic stability is essential. What does that mean? Femur fracture can lead to blood loss in a massive amount, especially in case of open fracture. The person, can bleed a lot, and we can see that. Even in case of closed fracture, the femur fracture can bleed a lot, and patient can develop hypovolemic shock. So hemodynamic assessment has to be done. Now see this. Average volume or average expected blood loss is about 750 to 1500 ml in shaft fracture of the femur, especially in case of closed fracture. In open fracture, I cannot say only this much blood is lost, okay, because the blood vessel can continue to bleed in case of open fracture. So this is a very high amount of blood loss. Thorough examination of the ipsilateral hip and knee should be performed. This is the principle of examination, isn't it? A joint above and below has to be examined properly, and when we take the X-ray, those two joints has to be included. Knee ligament injuries are common, however, and need to be assessed after fracture fixation. Now, in today's class, okay, I am going to talk about knee joint. And when we discuss, there are so many different ligament we are going to talk, like cruciate ligament, anterior and posterior. Okay, medial collateral ligament and lateral collateral ligament. So all these, we need to examine to rule out whether there is any injuries occurring to them or not. Now, please, all of you, okay, pay attention to this slide. If somebody has got a femur fracture, now how to transport this patient to the hospital? Okay, how to transport them to the hospital? This is done by Thomas splint immobilization. So usually what we do, we call the ambulance, isn't it? We call the ambulance. This is a very serious type of fracture. Patient cannot move at all, and very, massive swelling with a deformity occurs there. So we call the ambulance, and the person, okay, who comes there should have these certain instruments. Okay, so they immobilize the leg like this, and this is known as Thomas splint. We have already talked about this before. This is excellent way of transferring patient to the hospital. Now, regarding the associated injury in case of femoral shaft fracture, okay, the percentage is 5 to 15. So it is diagnosed by full body survey. That's why we have, included disability and exposure at the end, because A, B, and C is done to all the serious medical patients. There's no doubt about it. You have been knowing this from a long time. But D and E, okay, is added later, especially in the trauma case. Why? And the reason is to diagnose certain associated injury, to diagnose certain, muscle weakness or paralysis or dislocations or something like that. Now see there may be multi-system trauma in the patient. The same patient may be having rib fracture with pneumothorax. The same patient may be having head injury. The same patient may be having cervical spine fracture or pelvic fracture. You should examine spine, pelvis, and ipsilateral lower extremity injury, as well as ligament and meniscal injury, especially in the knee. Now, regarding the diagnosis, okay, clinical diagnosis is always done, and it is a very obvious type of diagnosis. We should confirm it by radiographic evaluation. Take the X-ray, anteroposterior and lateral view of the femur, hip, and knee is done. See that? If you pay attention, it is clearly mentioned the hip joint and knee joint are always included. Okay. Now, these are very easy type of topics because the most of the things we've done before. So we can go a little bit quickly here. So regarding the treatment of femoral shaft fracture, first is stabilize the patient. What do you mean by that? Stabilization of the patient means what? Yes. What is the meaning?
Immobilize the patient.
Okay, immobilize. Anything else? Stabilization means?
Hemodynamic
stabilization, airway, breathing.
And yes,
You can
And
do it.
also check the airway breathing in.
Exactly. I agree with your answer. This is again management of the vital signs, and again those A, B, and C. Airway management if airway is compromised. If there is pneumothorax associated in the patient, then treat that, find that out, and go for the treatment. If patient is in shock, okay, start IV fluid followed by blood transfusion. This is known as stabilization of the patient. So different books, mention the term differently, but you should understand the meaning. Okay, this is always the first thing. Now, let me give you one clinical scenario here. Sometimes what happens, a patient is brought with fracture femur, and there is a compound or open type of fracture, and continuous bleeding is going from there. Okay, so many of the time what the doctor will do, the new doctor or the beginner, they pay whole of their attention on that fracture site, and they completely forget about the airway and the breathing. And by the time they control the bleeding there, and do some dressing and things, patient is already dead because the airway was compromised in the patient. But this type of mistake should not happen. That's why, okay, we all the time teach our students airway first, breathing, then only circulation. Now, another is immobilization of the leg. Okay, that is done by Thomas splint. Now, how to treat the fracture? There are different ways. Okay, one is ORIF, open reduction and internal fixation with intramedullary nail or intramedullary rod, whatever you want to say, and that is kept either anterograde or retrograde. Now, anterograde or retrograde, I'm sure you know it because proximal and distal end of the femur, and from which end you insert it. Accordingly, the terms have been given. Another way is external fixator. Now, external fixator is not applied in all the patient. It is only used in unstable type of patient, open fracture, where we suspect there is a huge amount of contamination and highly vascular area. Okay, so external fixator is used. So we have discussed this before. Sometimes we can treat with plate and screws as well. Okay, so different types of open reduction and internal fixation can be used. One is intramedullary nail or rod, one is external fixator, another maybe plate or screws. After we go for that, there is early mobilization and strengthening exercise has to be done. Okay, this is a part of physiotherapy. This is a part of physiotherapy. Now, operative stabilization is the standard of care for most of the femoral shaft fracture. For the early mobilization, this is the best. And it should occur within 24 hours. There should not be any delay if you have decided to go for operative stabilization. This is the term for ORIF, open reduction and internal fixation. Let's move on. Now, let's see some of the picture, and that will give you very clear idea what we are talking here. For patients in whom surgery needs to be delayed, temporary stabilization with skeletal traction is required. Now, why? Why we go for skeletal traction in this type of cases? Any idea? Anyone? Anybody? For example, you cannot go for the surgery right now. You need to wait for 2 to 3 days, okay, because of different problem. Patients may be having other medical illness and you are managing that, for example, okay? So there may not be any experienced surgeon right now. So in that situation, you keep the patient under this skeletal traction. Now my question is why? Why we need to do this? Okay, and the answer is just to make sure these muscles, they are under spasm. They are under spasm, and because of this action of the muscle, there is a displacement going on. So if we give a good amount of skeletal traction, then the fracture is reduced. See there? The fracture is reduced. And the unnecessary, fusion of the bone will not start. And we don't even want that. We want the bony fusion in a proper way when there is complete reduction of the fracture. So because of this, principle, we go for skeletal traction. But remember, this is not the only treatment, this is only done for short duration. And later on, we go for specific management. And this is how the skeletal traction is given. We insert a pin through the, bone, that is tibial tuberosity, and hang around 5 to 10 kg of the weight. Usually 10 kg weight is hanged like this. This is skeletal traction. So these are the fixation option. Once again, it is repeated here because this is a very important question from the exam point of view. One is intramedullary fixation, also known as intramedullary nail or intramedullary rod. Another, see here, intramedullary nail or intramedullary rod. Second, open reduction and plate fixation, plate and screws. And third is external fixation. And external fixation has its own indication for open fracture, infected fracture, okay, and severe soft tissue injury. We definitely need to go for external fixation. Let's move on. Now let's see some of the picture here. Okay, see there, and try to understand what is going on here. This is intramedullary nail. See there, there is a rod or nail which is kept at the central part of the femoral shaft. There is a fracture line there. You can clearly see it here. Okay, and these are called interlocking nail. Interlocking because we fix towards the end. We fix these nails so that they don't shift here and there. So this is one of the excellent way of treating femoral shaft fracture. See this? There's a very bad looking fracture here, and this is nicely treated by intramedullary nail or rod. So this is one way. What is another way? Plate fixation. So there is a fracture, you can clearly see here, and this is how the plate is fixed on the surface with the screws. Plate with the screws, and this is the real X-ray, and this is how it looks after plate and screws. So this is another way of open reduction and internal fixation. Now this is external fixation, the third way. So this is external fixator. You can see here the rod is always kept outside, okay, and the long pins are inserted above and below the fracture site. Okay, this is external fixator. So see that. Okay, absolutely same X-ray. This is a fracture here. This is the outside rod. Okay, and these are the long nails. Now this is a real patient picture. See this. This is external fixation. External fixation. Okay, the outer part, and these are the long nails which are inserted inside, either above or below the fracture site. Exactly like this. Now look at this horrible looking fracture. Okay, sometimes patient present like this. Now what is this? What is the classification of this fracture? Quickly, what we call this? Yes.
Open fracture.
Exactly. Exactly. This is open or compound fracture. Open or compound fracture. There's no doubt. Look at the amount of tissue injury there. And this has to be treated by external fixator. There's no other way. I cannot even think of any other way here. External fixation is the treatment. Now, what about children? If they break the shaft of the femur, then how do we manage their fracture? Now, see that. As per American Academy of Orthopedic Surgeon guideline, we treat this fracture shaft of the femur in children according to the age. If the age is less than 6 months, we go for Pavlik harness or early spica cast. Okay, I've collected some of the picture here and you'll clearly understand how it looks. Okay, let me finish this first. From age 6 months to 5 years, early spica casting, traction with delayed spica casting, open reduction and internal fixation with submuscular bridge plating, means below the muscle, okay, the plate is applicable or applied. Sometimes the flexible nails like Anders nail, which is made up of stainless steel, or titanium elastic nails, also known as TEN as a short form, can be used. These are quite flexible type of nails. And the last one is external fixator. So all these different, process, okay, or maneuver can be applied in the treatment of fracture shaft of the femur in children. Now, let's try to understand by looking at the picture. See here. This is known as a Pavlik harness. Okay, this special type of device is fixed on the body of the child, okay, and it has a different parts. It's a shoulder strap, chest strap, abdominal strap, abduction strap, and the leg strap, and it will nicely immobilize the child. Okay, so this is just one way. It is used in a very young child, less than 6 months. It's easy to carry the child like this as well. Another is a hip spica cast. See this is called hip spica. So we start the plaster right from the trunk area, okay, middle part of the trunk. Then, okay, we include uh, the fractured leg, okay, up to the very distal area, and even the other leg which is not fractured, we need to put plaster till the upper part of the knee. The place, okay, which is in front of the genital area and the anal area is left open. This area is left open. This is known as spica or hip spica cast. Now, gallows traction, I'm sure you still remember this picture. We have discussed this before. Gallows traction is one of the way of treating femoral shaft fracture in small children. Okay, so this type of position is attained for a few weeks, and the fracture will be healed. And this is the Thomas splint in case of pediatric age group. It is just an immobilization method. These are the different type of flexible intramedullary nail fixation. It can be stainless steel, which is known as Anders nail, or titanium elastic nail system. Okay, so these are some other options. See that these are flexible type of nails. They can be bent easily. So this is the way. In adults, we cannot use this usually because they are a bit of flexible. If they use their body weight, then they can be bent excessively. But in children, we can go for this. Now, some other thing. Let's talk about it. From age 6 to 11 years, and when the age is more than 11 years, how do we manage this type of fracture in children? From age 6 to 11 year, we go for open reduction and internal fixation with submuscular bridge plating. Submuscular bridge plating. This is application of the plate, okay, below the muscle and above the periosteum of the bone. So this is known as submuscular bridge plating. This surgery can be done without giving a big incision. This surgery can be done by giving two incisions, one in the proximal area and one in the distal area, and they do appropriate dissection through this opening and then insert the plate through this opening and apply it there. Okay. Another is a flexible nail, Anders, that is stainless steel, and this is titanium elastic nail. And another is by external fixator. External fixator has its own indications, just like adults. We don't go for this in every children. When age is more than 11 year, it is a bit like adult type of treatment. Anterograde intramedullary interlocking nail, open reduction and internal fixation with submuscular bridge plating, flexible nail, Anders or TEN, though we do not go for this in adult, but still in children it can be considered an external fixator as the last option, especially in case of compound fracture. Okay, now at the end of this important class, what are the complications of femoral shaft fracture? Now all of you please go through this slide, and I'm sure there is not even one new term there. Everything we have discussed before. Okay, so just go through this. So you can answer this in any way. You can just list the complications, or you can answer like early or late complication. It's up to you. So hemorrhage requiring transfusion, because femoral shaft fracture can bleed a lot. They can easily lead to hemorrhagic shock. Fat embolism leading to ARDS can occur. We have talked about this. extensive soft tissue damage, which is known as compound fracture. Ipsilateral hip dislocation or fracture can occur in 2 to 6% of the case. Neurovascular injury, okay, can occur. Sciatic nerve injury, femoral nerve injury, femoral artery injury. Compartment syndrome, we need to correct the spelling here. Compartment syndrome can occur, and this is a very serious condition. Infection, very common to occur in open or compound fracture. Fixation failure, failure of ORIF, non-union or delayed union, malunion, and heterotopic ossification, also known as myositis ossificans. These are the common complication. Now, if I divide them into early and late complication, okay, early can be shock, fat embolism, infection, and thromboembolism, and late would be delayed union, non-union, or malunion, stiffness of the joint, both hip as well as knee stiffness. There may be a chance of refracture and implant failure, especially in case of infection. The implant has to be taken out. We wait for the infection to heal and put it back again, and shortening of the limb. So these are some of the common complications in femoral shaft fracture.